Very good afternoon, everyone. So, as a part of this postgraduate teaching program or the undergraduate teaching program, today I thought I'll present some interesting cases from the Department of Pulmonary Medicine. For the last 3 months, most of us has been full of COVID information. Our day starts with COVID and day ends with COVID, and during the day we keep discussing the COVID. So, there is a lot of COVID toxicity. Here today I thought let us discuss some interesting cases from the Department of Pulmonary Medicine, and at the end maybe we can take some questions. You can post your questions in the YouTube link which have been provided to you, so we can take up the discussion. So, as a part of my presentation, this is the first case which I am going to present. 23-year-old female, the patient presented with cough and loss of appetite, and the patient had fever. The sputum AFB was negative. So, this patient was diagnosed as having sputum negative tuberculosis and then started on anti-TB treatment. So, you can see that in the CT scan, there is a large mass in the hilum region which is compressing the superior vena cava. You can see that like this is the superior vena cava. This is, let me put out the pointer for you. So, this is the superior vena cava which is compressed with the mass, and again you can see that the mass is also surrounding the aorta, and here this is the main pulmonary artery, and this is the right pulmonary artery, and this is the left pulmonary artery. The right pulmonary artery is entirely compressed with the mass lesion, okay, and you can see that this lesion is also extending into the lung. Actually, the middle lobe is also involved. So, the reason why she came to us is that this patient's symptoms were not improving. The cough was persisting and the fever was persisting. That was the reason why this patient came to us. So, the differentials of metastatic carcinoma, thymoma, lymphoma were considered in this patient. If this was a one-to-one session, probably we would have had a very interactive session regarding the differential diagnosis and the possibilities. It would have been much more vibrant and interesting to discuss actually. But since it's an online presentation, because of the COVID concerns, we are to maintain this physical distancing, we have started this as a virtual program, which we used to do it in real time earlier. So, the differentials, these were the differentials considered. You know that generally the infections do not cause infiltration of the vascular structures. If a vascular structure or the surrounding structures are being infiltrated by pathology, generally it goes in favor of a malignancy. So, that was the reason why we thought this patient was having a metastatic carcinoma, and the second possibility is thymoma, which we considered. Reason being, it's an anterior mediastinal mass lesion, and again one more possibility which we considered was lymphoma. So, this patient underwent a CT guided FNAC prior to coming to us actually, and also biopsy. Both the times the biopsy and the FNAC were inconclusive, and then the patient was started on empirical anti-TB treatment as I've mentioned earlier. So, this patient, so when she came to us, the patient underwent endobronchial biopsy and EBUS guided transbronchial needle aspiration from the mass. So, you can see that this is the mass which is homogeneous on the EBUS image, and this is the superior vena cava. This is the paratracheal lymph node, and this is the superior vena cava. Okay. So, after visualizing the mass and EBUS, what we do is we take the measurements, we assess whether the lesion is vascular or not, and then after taking all these basic measurements, we stick in a needle into the mass under the guidance and take biopsies and FNACs. One important thing to remember is EBUS has come in the last decade. In 2012, it was 10 to 12 it was introduced. However, before the advent of EBUS, actually, if we had any mediastinal lymph node or mass, the only approach for biopsy of these lesions used to be the mediastinoscopy. However, after the advent of these EBUS guided procedures, now we can easily do it under the guidance actually. You can see that under the guidance we are sending a needle into the mass and then taking a biopsy. And this was the patient's report. We can see that the patient was having granulomatous inflammation, and you can see that this fungal profiles are clearly seen on the GMS stain. So these were all aspergillus related fungal profiles. So this was an aspergillus related mediastinal fibrosis. Fibrosing mediastinum occurs because of malignancies, because of tuberculosis. Sometimes radiation can cause fibrosis. However, sometimes this unusually these kind of fungal infections like aspergillus can lead to mediastinal fibrosis. So this patient was given treatment with voriconazole, and post voriconazole you can see the treatment response here. This is the pre-treatment X-ray. You can see that the X-ray is showing a large hilar mass lesion in the X-ray, and after the 7 months of treatment you can see the post-treatment X-ray. The X-ray is showing resolution of the hilar mass lesion. And let us also see some of these CT slices. You can see that the mass here, this is a pre-treatment CT scan. You can see that the mass is encasing the pulmonary artery and compressing it. Okay, so this is the original caliber of the pulmonary artery. The branch pulmonary artery should be slightly lesser in size. So here you can see that the pulmonary artery is totally compressed actually, and it has reduced blood supply to the right lung. So after the treatment you can see that the compression effect on the pulmonary artery is totally lost, and the blood supply to the right lung is restored. And again you can see that there is an lesion in the lung parenchyma here, and after 7 months of treatment you can see that the consolidation of the mass like lesion in the lung parenchyma is totally resolved. And subsequent CT slides, let us compare the CT again, the same patient's CT scan at the level of the right middle lobe bronchus. This is the right middle lobe bronchus. Again you can see that this lesion which was here and then the lesion which was there in the parenchyma, both have resolved. So looking at this, is a very interesting case of aspergillus related mediastinal fibrosis which responded very well to voriconazole. And again we have one more interesting case of patient who presented with an aspergillus lung and kidney mass. This patient again presented with an non-resolving paratracheal mass lesion, and then this patient was treated with anti-tubercular treatment, and then was even given steroids based on the report of an transbronchial needle aspiration showing an granulomatous inflammation. So after the treatment with voriconazole, this patient also responded. So in this patient, after the failure of this anti-tubercular treatment and steroids, this patient came for a definitive diagnosis. Then again we did an EBUS guided biopsy from this mass lesion, and the mass lesion showed that biopsy showed again granulomatous inflammation with evidence of fungus on the histopathology, GMS stains, and also the cultures also. So this patient also did respond very well to voriconazole. This patient we had to give treatment with voriconazole for a total of 10 months duration, after which both his lung mass as well as the kidney mass resolved. So few learning points from this both these cases are: the clinical presentation of fungal infection is often similar to that of other infections like tuberculosis. Sometimes these lesions may mimic malignancy because they present like masses. So masses, generally when we look at any mass in the CT scan or X-ray, the first differential diagnosis which comes to a person's mind is malignancy. You can see that this both patients presented with mass. One patient presented with an infiltrating mass lesion in the anterior mediastinum, and the second patient presented with an big mass lesion in the paratracheal location. In the second boy, 13-year-old male boy, in that boy also had a kidney mass. So they can present like masses, and these masses can sometimes be confused for an malignancy. So important point is that it's, they can present similar to that of tuberculosis and malignancies. So high index of clinical suspicion is the key to diagnosis, and most important thing is tissue is the issue. You need to take a do an FNAC or a biopsy by any kind of route depending upon where the lesion is. Suppose if the lesion is closer to the chest wall, maybe we can use an ultrasound guided FNAC or CT guided FNAC from the lung parenchyma. But if a lesion is very closer to the tracheobronchial tree, then we use what is called as EBUS guided procedures for aspirating these lesions from the mediastinum. Sometimes these lesions will be in the middle, which is not closer to the chest wall, or where they are not closer to the hilar region. So for these kind of lesions, we use technology called as a radial EBUS or a navigation technology to reach that lesions which are in the center of the lung parenchyma to take a biopsy. And whenever you're doing a biopsy, when you have a high index of suspicion towards a fungal infection, it is also appropriate to take cultures like TB cultures and fungal cultures to make an appropriate diagnosis. So with the increasing number of patients on immunosuppression, especially we are seeing the number of patients who are increasing because of immunosuppressed patients, because of kidney transplant, liver transplant. Some of these patients are on cancer chemotherapy, some of them are post bone marrow transplant. So there are a lot of reasons why these patients might be immunosuppressed, like patients are like autoimmune conditions like SLE, systemic inflammatory conditions, autoimmune disease. All these patients are steroids or alternative immunosuppression, mycophenolate, azathioprine. All these conditions may predispose the patients to risk of fungal infections. That is the reason why we need to have a high index of clinical suspicion and take appropriate measures to get an FNAC, biopsy, cultures to make a correct diagnosis. These days we have in fact PCR based test like Gene Expert, and for fungal infections also we have PCR based diagnostic modalities. So we need to send even the molecular based techniques for making an appropriate diagnosis. So the most important thing is a lack of clinical, even if a patient has been started an antitubercular treatment, and if the patient fails to respond on this antitubercular treatment, then this should prompt further workup of the diagnosis, basically by the tissue diagnosis and microbiological test. Satya, can we take up questions later on? This will be sent in the YouTube only, right? In that link only. Okay. Okay. So again, coming to a next set of disorders, which again are interesting. Generally these are less suspected and less diagnosed. Pulmonary vascular conditions due to different kind of presentations, and sometimes there are no classical symptoms or signs of pulmonary vascular disorders. That's the reason why this might be missed. So let us see a case of pulmonary vascular disorder. A 24-year-old male patient who was studying, I think, BCom, and he presented with history of acute abdominal pain, vomiting and fever of 2 days duration, and the ultrasound abdomen was normal, and conservative treatment with proton pump inhibitors and the painkillers were given, and the patient was discharged outside. So in view of the recurrent pain abdomen after the discharge, he came to AIG for further evaluation of the abdominal pain. When he came in, there was no respiratory complaints, but only we noticed that the patient was slightly tachypnic while exerting, while walking, and when he walked into the outpatient room. So the vitals were stable, the physical examination, systemic examination was normal, the resting saturation was normal, 97%. However, during the 6-minute walk test, the patient had a significant desaturation from 97% to 73%, and the distance covered was 360 minutes. So just a small note on the 6-minute walk test. So 6-minute walk test is an test in which you make the patient walk for 6 minutes at the pace which is comfortable at. You decide a length of 30 meters, and then the patient is made to walk in this lap of 30 meters. So we count the number of laps the patient walks in the 6 minutes time at his comfortable pace. We measure the vitals pre and post test, the heart rate, blood pressure and the saturation, and then we check it, we compare the pre and post values. Normally the normal 6-minute walk test distance for an adult male or female Indian is around 500 to 600 meters. There is an algorithm which tells us, and there is also a nomogram which tells us what is the average predicted 6-minute walk distance. So it gives us an average capacity of the cardiorespiratory system, and when you are diagnosing a patient with some kind of disorder like interstitial lung disease or chronic obstructive pulmonary disease, severe PAH or heart failure, whenever we give them some treatment, so to compare whether the patient is improving or not objectively, this is one of the tests we can use it on the follow-up of the patients, objectively measure whether the patient is improving or not. Suppose if you given pulmonary artery hypertension treatment like sildenafil or tadalafil or some kind of bosentan or ambrisentan. So you assess the patient whether the patient's symptoms have improved or not, and then objectively you will see whether the patient's 6-minute walk test has improved or not. When the patient comes on follow-up, you compare the baseline saturation, desaturation percentage and the distance walked pre and post. Okay. Suppose you feel that the current distance is 360 meters, and next time when the patient comes, if it improves to 400 meters, that is a sign of improvement. So both we look at clinical improvement and objective improvement of the patient to decide whether a therapy which has been given to a patient is working or not. So coming back to this patient had a significant desaturation of 97 to 73%. The distance covered was 360 meters. Normally there should not be any desaturation. A desaturation more than 3% is considered as a significant desaturation. So the patients had a significant desaturation. That means to say that there is a significant pathology which is causing this desaturation. So mind you, the chest X-ray is normal. So we always have learned from our MBBS days that when a patient's breathlessness or hypoxemia is disproportionate to the chest X-ray findings, what is the thing to be suspected? It is pulmonary thromboembolism. Here similarly, as this patient's chest X-ray was normal, clinical examination was normal, and there was a desaturation and exertion. So we suspected that this patient might be having an underlying pulmonary thromboembolism. We did an ECG. The ECG showed normal sinus rhythm, and echo showed a normal LV function. And this is the 6-minute walk test, where you can see that the patient's saturation has dropped from 97% to 73%, and the distance walked is around 360 meters. If you look at this CT scan report, the CECT abdomen was initially done, and later on when the abdomen lower CT cuts showed that there was a thrombus, we also did an CECT chest. So in the CECT abdomen, we found that this patient was having portal vein and splenic vein thrombosis. There was no contrast filling at all, and there was an eccentric thrombus in both the lower lobe pulmonary arteries. So this was a patient with concomitant thrombosis in both pulmonary arteries and in the mesenteric circulation. This was a case of an concurrent intestinal circulation, that is the portal circulation thrombosis and the pulmonary artery thrombosis. So, and the history, when we again look back retrospectively, when we asked the patient had a history of DVT of the lower limb earlier. So this means this patient was having some kind of prothrombotic condition predisposing him to recurrent thrombosis. Now he had a lower limb thrombosis, pulmonary arteries and mesenteric circulation. So we did workup for all the genetic markers. We know that deficiency of protein C, protein S, antithrombin 3 deficiency, factor V Leiden mutation, prothrombin gene mutation, these are some of the conditions which can predispose to recurrent thrombosis. From our MBBS knowledge, you know that all of these, okay. And serum homocysteine is also well known to cause increased risk of thrombosis. So in these patients, rest of all the workup was negative, but the serum homocysteine levels was elevated, 52, the normal cutoff being less than 15. So this patient we have treated for the homocystinuria. So we have asked these patients' family members to get tested to look if it is any kind of disease like familial homocystinuria, and we have also supplemented this patient with B6 and the folic acid vitamin, which are generally given in patients with homocystinuria. And coming to one more patient, the similar kind of history actually, the patient presented with shortness of breath and hypoxemia. He was a 32-year-old male, and he had a prior history of extrahepatic portal vein obstruction, and he underwent a splenectomy for this extrahepatic portal vein obstruction in 2007. This time the patient was having breathlessness for 2 months duration, which was exertional on especially on walking, which has progressed from grade 1, and gradually the patient became so breathless that even on minimal exertion or at rest he was having breathlessness, and he was hypoxemic at rest. He was maintaining a saturation of 85-86% on room air, and he also had mild cough. He was initially hospitalized at Nellore for his breathlessness and hypoxemia, and there he underwent some basic workup, and you can see that we don't have a cardio X-ray now immediately, but there was a cardiomegaly, and 2D echo was done. 2D echo showed that this patient's did have an RARV dilatation with severe pulmonary artery hypertension, and there was RV dysfunction. I think the CT is not playing, but in the CT we had some opacities in the lung, in the lower lobes, some fibrotic opacities. So based on the CT plane report of this fibrotic opacities in the lower lobes, this patient was labeled as having an chronic lung disease with pulmonary arterial hypertension. That is, he was labeled as having an cor pulmonale outside, and then he was given oxygen to be taken at home, and they said that there is no he has been told that there is no permanent treatment for this cor pulmonale. Then he need to just continue using oxygen at home. That was the time when he came to us. When we evaluated him, the pulse rate was 118, tachycardia, tachypnea, and then you can see that the room air oxygen is 88%. On slight exertion, the saturation was dropping down to 74%. His BP was on the lower side, chest was again clear. This was the X-ray, and this was the 2D echo findings, and you can see that there is cardiomegaly in the X-ray, and the pulmonary arteries are prominent. You can see that this is the right descending artery which is prominent, and the left side also you can see the prominent pulmonary arteries, and the 2D echo RA and RV were dilated. There was a severe pulmonary artery hypertension, and the patient's RV and systolic pressure was 72 mm Hg, and ultrasound abdomen was done, which showed that patient was having a post-splenectomy status. There were no new findings within the ultrasound. So since this patient underwent a splenectomy at AIG earlier, then he came with an hope that we might solve his problem of his breathlessness, because the earlier hospital he visited, he was told that there is no permanent cure for that. That was the reason why he came here, and to a surprise, this was the CT findings we found actually. You can see that this is the arch of aorta, and this is the superior vena cava, okay, and you can see that there is a thrombus in the pulmonary artery. This is the main pulmonary artery, and this is the right pulmonary artery, which is showing a large thrombus within the right pulmonary artery. You can see that there is a thin sliver of contrast which is passing surrounding this thrombus. So it was an like large thrombus which is sitting in the major right side pulmonary artery. That was the reason for this patient's breathlessness. And you can see that even this thrombus was extending into the segmental arteries. This is one of the segmental artery of this right upper lobe, and again this is one of the pulmonary artery branch again, where you can see this thrombus. So this patient was having an pulmonary thromboembolism which was submassive. The patient was started an anticoagulation with rivaroxaban. So one of the things to be remembered in pulmonary thromboembolism is, if a patient is having an pulmonary thromboembolism which is causing a blood pressure drop more than to blood pressure to less than 90/60, it is considered as a massive pulmonary thromboembolism. When a patient has a normal blood pressure, however his RA, RV are dilated, or if there is an RV dysfunction or RV dyskinesia on the 2D echo, it is called as a submassive pulmonary thromboembolism. So there are different guidelines for treatment of this different severities of pulmonary thromboembolism. If the patient is having a mild pulmonary thromboembolism, that is, the patient does not have any hypotension, and that the patient does not have any evidence of RA-RV dilatation or PAH or RV dyskinesia, we call it as an low risk pulmonary thromboembolism, or segmental pulmonary thromboembolism, where you just need to treat the patient with anticoagulation. So here in this patient was having pulmonary arterial hypertension. However, the blood pressure of the patient stabilized. So that was the reason why we gave only anticoagulation in this patient. When we started this patient on rivaroxaban, after months of follow-up, his hypoxemia improved and is off oxygen. So some of the important learning points from this case are pulmonary thromboembolism is less commonly suspected and diagnosed. Often these patients are, when the patients present with pulmonary arterial hypertension, these patients are labeled as primary pulmonary hypertension or cor pulmonale. So you need to label a patient as having cor pulmonale only when a patient is having an irreversible lung disease like interstitial lung disease or a severe severe chronic obstructive pulmonary disease. Only a severe lung disease can lead to cor pulmonale. So cor pulmonale is basically nothing but a pulmonary hypertension which occurs in the setting of lung disease. Sometimes this pulmonary arterial hypertension can occur because of the left heart disease. Sometimes the pulmonary arterial hypertension can occur because of this lung disease. So there are different kinds of classification for pulmonary arterial hypertension. So the class 1 according to the international classification for PAH is primary pulmonary arterial hypertension, wherein the heart, lungs are normal. It's primarily the disease in the arteries. There is a proliferative arteriopathy. The arteries are getting narrowed. That is called as a pulmonary arterial hypertension. Class 2 is because of the left heart disease. Sometimes if you have a mitral patient with a mitral stenosis or mitral regurgitation or any kind of valvular heart disease, this on a chronic thing, when the patient gets exposed to this, the pulmonary circulation gets exposed to the increased pressure in the left heart, so they develop a pulmonary arterial hypertension. So this is class 2, which is secondary to left heart disease, and class 3 pulmonary arterial hypertension is secondary to a lung disease like COPD, interstitial lung disease or sleep apnea, and class 4 pulmonary arterial hypertension occurs because of underlying thrombus in the pulmonary circulation, and class 5 is because of the miscellaneous conditions like sarcoidosis. There are a lot of other conditions like chronic kidney disease, histiocytosis, some kind of storage disorders. There are a lot of miscellaneous diseases which can cause this class 5 kind of pulmonary hypertension. So in this patient, as you can know that this pulmonary hypertension in this patient is class 4. So that is because of the thrombus in the pulmonary circulation. So now shifting the gaze, we have seen some of the clinical cases, some of the fungal infections presenting with like presentation like tuberculosis. We have seen pulmonary vascular disorders. Now let us switch to some interventional cases which will be interesting to see. This was an 80-year-old male patient who presented with an esophageal carcinoma. The patient had an esophageal stent inserted for his dysphagia outside, and this time he presented with a history of postprandial cough, sputum and vomiting for 3 months duration, and with a progressive shortness of breath for 1 month duration. So the CT scan showed that there was a tracheoesophageal fistula. You can see that both the trachea and the esophagus, the anterior structure is the trachea here, what I am showing you, and the posterior structure is the esophagus. So you can see that both of them are joined actually. So it's a tracheoesophageal fistula. Again, when we did an endoscopy for this patient, we found out that the stent which was placed for his dysphagia for the esophageal carcinoma was eroding into the trachea, and again this was the stent. You can see that the stent was broken inside the esophageal lumen. It was coming into bits and pieces. So again, when we evaluated this patient, so this patient was again, I think this video is not, yeah, no. So you can see the stent. Basically this is the lumen of the trachea. This is the bronchoscopic image. You can see that the stent is coming into the trachea. So the esophageal stent is basically coming into the trachea. It was something scary to see actually. One stent coming into the other lumen. So this stent was finally taken off with the help of our gastroenterology team, and Dr. Mohan Ramchandani was taking care of this patient. So we were able to pull off this stent from the esophagus. Okay, and then subsequently we found that there was a large fistula sitting in this trachea, and then we had to put an tracheal stent to cover this fistula. Yeah, let me go back to this. And in this patient, I'll just show you a small video which shows us the fistula. This is the bronchoscopic video. You can see that this patient's fistula is clearly seen on the posterior wall, and this is the fistula on the posterior wall. We were able to go into the esophagus freely from the tracheal lumen. And since this patient was having a large fistula in the posterior wall of the trachea, we put an stent into this patient's tracheal lumen. This is called as a metallic stent. This is called as a self-expanding metallic stent, SEMS. So this is the catheter which is used to deploy the tracheal stent. We take this catheter beyond the fistula, and then we push the stent into the trachea. So you are able to see the stent being deployed. Under the vision, we were gradually able to push the stent into the trachea, and our aim is to see is that the fistula is totally getting covered when you are deploying an stent. Stent is applied for different reasons. One, sometimes when patients have central airway obstruction like tracheal stenosis because of malignancies or because of intubation, post-intubation tracheal stenosis, post-dilatation, to maintain the patency of the trachea, we put in tracheal stent. Okay, and sometimes when there are fistulas, to cover the fistulas, we put in stent. If you have a benign tracheoesophageal fistula, then surgery is the first line of treatment. And if you have a malignant tracheoesophageal fistula, stent is the primary mode of treatment. So, and we checked that stent was deployed very well within the C-arm. This is the C-arm, that is the fluoroscopic image. So, again, you can see the bronchoscopically the stent has been beautifully placed, well placed and covering the fistula. And again, when we did an X-ray to find out that the position was in correct position, the patient's stent was in correct position. And this is more than a year since we have put this stent. We have put this stent in last May, and this patient has come for last follow-up in the month of February. We are planning to take off the stent for this patient next time when he comes in follow-up. So this patient, being an elderly male, we are expecting a lot of anesthetic complications, but luckily this patient tolerated the procedure well. There was no bleeding, and we were able to collaboratively work and offer an stenting service for this patient. And this case is a patient to exemplify that all that wheezes is not asthma. Generally, when we see a patient, and if a patient is having wheezing, then we come to a conclusion this patient is having wheezing. But it should be remembered that a lot of other conditions like congestive heart failure can cause wheezing. That is why it is called as a cardiac asthma. Conditions like chronic obstructive pulmonary disease, sometimes foreign body aspiration, which can get blocked into the either of these airways, either into the bronchi or into subsegmental airways or segmental airways, can lead to wheezing. Sometimes aspiration pneumonitis can lead to wheezing, and sometimes allergic bronchopulmonary aspergillosis. Lot of other conditions can lead to wheezing. Just don't think that asthma is the only condition which causes wheezing. So this was a patient who presented with 54-year-old male patient who presented with wheezing. Patient was having a chronic kidney disease, and the patient was ventilated for respiratory failure, and the patient was having accelerated hypertension with pulmonary edema. So in view of this post extubation, the patient was treated for asthma because he was having wheezing and noisy breathing on exertion for last 2 months. So the bronchoscopy was done, and in the bronchoscopy we found that there was an web-like stenosis, and then the web-like stenosis which was 2 centimeters from the vocal cords. So this patient was given electrocautery cuts to the web, followed by balloon dilatation up to 14 mm. So the stridor resolved, and this patient on follow-up is doing well. This is the web-like subglottic stenosis, and these are the electrocautery cuts which are given to this patient. And post cuts we have dilated with a balloon, and you can see that this was the pre-bronchoscopic dilatation image which was showing a tracheal stenosis, and you can see that the tracheal lumen is very large. Okay, so you need to be aware that if a person is intubated and ventilated for a reason, any reason, cardiorespiratory reason or some other reason, sometimes these patients can develop what is called as an post-intubation tracheal stenosis or PITS, which can happen after intubation, or sometimes it can also happen after tracheostomy insertion. So when a patient is coming after the discharge from a critical care center, and if he is having wheezing, so you should suspect post-intubation tracheal stenosis in this subset of patients. So the last case actually, let me see which was. So we'll quickly go through the last 2 cases. A 70-year-old male patient presented with lethargy, nausea and vomiting. The patient also had weight loss of 5 kgs in 2 months. This patient was a heavy smoker and he quit 30 years ago. The patient had diabetes and hypertension and no significant past history. He was on metformin and cilnidipine, and in the X-ray you can see that there is an paratracheal prominence, okay, paratracheal, and is also extending up to the hilar region. So this patient was having an mediastinal lymphadenopathy which is predominant in the paratracheal and hilar region. So this patient's ECG was normal, echo was normal, and then we evaluated him with a PET CT scan because we were expecting a malignancy in this patient, and you can see that this is the PET CT scan of this patient. You can see that this large bright thing is the paratracheal mass lesion, okay, and this is the subcarinal mass lesion, and this is the hilar region. So the bright things are the lymph nodes actually. So we did an EBUS for this patient, and again found that the patient was having malignancy. It's a small cell carcinoma of the lung. So this patient, the presentation is important. This patient presented with just nausea and anorexia and some weight loss, and the sodium was low. That was the only reason why this patient underwent an PET CT scan to know if there is any evidence of malignancy, especially in patients who are smokers and patients who are at risk of malignancies. When you have a low sodium, it's we should have a high index of suspicion for malignancy. In this patient, the sodium was low, and then he was a heavy smoker. X-ray was showing an hilar opacity. So that was the reason to test this patient with a PET CT scan, and subsequently this patient was diagnosed as having small cell carcinoma. And the last case, patient who presented with 40-year-old female, 48 female, presented with weight loss, and you can see that the patient was having hypothyroidism. There were no respiratory symptoms. Patient was not a diabetic and hypertensive. Because of the weight loss, she underwent a master health checkup, and this patient's chest X-ray showed bilateral inhomogeneous shadows. You can see that there are bilateral inhomogeneous shadows, and the CT scan chest and abdomen were done. In the CT scan abdomen, there were bilateral patchy opacities and mediastinal lymphadenopathy. There were large adenopathy in the abdomen, celiac, paraaortic, mesenteric lymph nodes, hepatosplenomegaly, and hypodense nodules in the liver and spleen. So this is the CT scan lung parenchyma, which is showing fine nodularity. This kind of nodularity which occurs along the vascular bundles, which occurs along the bronchial tree, or which occurs along the septa of the subpleural, it's called as a perilymphatic distribution of nodules. This kind of nodularity is commonly seen in patients with sarcoidosis or patients with lymphangitis carcinomatosis. So this patient underwent an diagnostic procedure, and we did an EBUS, transbronchial biopsy, and transendobrronchial biopsy and aspiration from the lymph nodes. And this patient's findings were very classical of sarcoidosis. There were Shaman bodies, asteroid bodies, which you might have read in your MBBS days. And this was the presentation of the patient: weakness, loss of appetite, weight, little bit of dry cough for last 10 days before she came to us, breathlessness and exertion. And this were the vitals. She was having a normal saturation and the vitals were normal. These were the differential diagnosis which we have considered. She was given anti-TB treatment before she came to us, but looking at the pattern of the nodules, we felt that the patient might be having an sarcoidosis. This is the typical pattern of sarcoidosis. And one more differential which we considered in view of the generalized lymphadenopathy was lymphoma. And in the routine investigations, the ESR was elevated. Serum ACE, angiotensin converting enzyme levels were elevated. You can see that the levels are 3 times above the baseline, and rest of the other investigations are normal. The 2D echo was normal, did not show any PAH or no diastolic dysfunction. PFT showed a severe restriction and with no reversibility. This is the X-ray showing a lot of parenchymal shadows in the lower zones. And these are the images of the PET actually, and we found that this patient was having an uptake FDG avid lymph nodes both in the mediastinum, and the parenchymal nodules were also FDG avid. These are the lymph nodes here. So this is the paratracheal lymph node. So there was a liver and splenic involvement, and the mediastinal lymph nodes, abdominal lymph nodes, and the lung parenchymal involvement. So this is the thing which I was mentioning. There were non-caseating granulomatous inflammation with Shaman bodies and asteroid bodies. So this patient was finally diagnosed as having sarcoidosis, and then was started on immunosuppression with steroids, and post immunosuppression with steroid, the patient stabilized. The cough, the breathlessness, exertional breathlessness which the patient was having, and the weight loss, everything stabilized. The chest X-ray showed improvement. He came for follow-up today also, and this patient is stable now at the moment. The X-ray has stabilized, pulmonary function test has improved. Only this patient has developed a mild arthritis, and the ultrasound was done to look for synovitis. The ultrasound of the joints was showing inflammatory arthritis. That is, sometimes patients with sarcoidosis can develop arthritis. So this patient has been put on methotrexate along with the hydroxychloroquine. But more or less the patient's other systematic symptoms have improved. So just to sum up, we have discussed today cases which have unusual presentation like fungal infection which can mimic like masses, which can be confused for tuberculosis or malignancies. And the second subset of disorders which we discussed is pulmonary vascular conditions, in which pulmonary thromboembolism is a main thing. As you have seen that, we have seen that both the patients had an atypical presentation. One of the patient presented with an abdominal pain, and when there was a desaturation in the 6-minute walk test, we suspected pulmonary thromboembolism and did an CT pulmonary angiogram. We treated this patient with anticoagulation, and the second patient also was having a severe pulmonary arterial hypertension with because of pulmonary thromboembolism. So, and the third subset of disorders which you have seen is the conditions presenting with upper airway obstruction. Basically, one patient presented with an esophageal carcinoma with the stent erosion, and the other patient presented with a tracheal stenosis. So you should understand that patients with this central airway obstruction. Central airway obstruction is defined as obstruction of the trachea or obstruction of the major bronchi. So when you have obstruction of this trachea, the major bronchi, these patients can have breathlessness or a lung collapse. So they should be managed by using a rigid bronchoscopy, different modalities like dilatation of the trachea, bronchi. If there is a tumor, we need to debulk the tumor, and if there is a collapsible upper airway like extrinsic compression, then you need to put in tracheal stent to keep the trachea open. And in the last, you have seen an interesting case of a patient who presented with weight loss. Generally, when a patient presents with weight loss in our country, the first thing which comes to us is tuberculosis. and sometimes we think of HIV. The other important differential diagnosis we need to think of when a patient presents with weight loss is any kind of systemic condition which can cause weight loss. Some of the conditions are diabetes mellitus, which can cause the weight loss, and the diabetes mellitus weight loss is generally associated with nocturia or polyuria, and sometimes you can see conditions like sarcoidosis which can present with weight loss. So the evaluation of weight loss itself is a very detailed thing, but you need to remember that if a patient presents with weight loss, tuberculosis, HIV, diabetes mellitus, and some other systemic conditions like this, autoimmune conditions like autoimmune diseases, vasculitis can cause weight loss. And this sums up my presentation. We can have some discussion questions on this, the questions in the cases which have been presented. Thank you all. Satya, can we have questions? Satya? 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 Can we have some questions? If they have questions, our people. Huh? Huh? Any other infection? Okay, any other infection? So the question is, I think, what are the things to be suspected when ATT fails? One is when ATT fails for a patient who is suspected of having tuberculosis. One thing is you should see whether the patient is taking the medications properly or not, compliance is good or not, and the medications quality which the patient is taking is good or not. Sometimes there can be drug interactions. Sometimes the drug might not be absorbed very well, or sometimes they might be on some drugs which can decrease the levels of anti-TB drugs. This interaction can reduce the efficiency of the anti-TB medications. And sometimes if the patient is having coexisting conditions like uncontrolled diabetes mellitus, then the patients may have weight loss. They may not have any weight stabilization, or weight gain may not be there. In addition to these conditions which I have mentioned to you now, sometimes if you have a multi-drug resistant tuberculosis, then the patient might not respond very well to treatment and the weight loss can continue. And sometimes, as you have seen in this case, there can be conditions like sarcoidosis, and sometimes malignancy is one which need to consider if the weight loss is persistent. So that is the reason why it's important to make an appropriate diagnosis when you start a patient an anti-TB treatment. Without having a proper diagnosis, don't start the patient on TB treatment. Any other question? So I think since there are no questions, I would like to end my talk here. I thank you all for an patient listening. Maybe we can take questions one-to-one during our interpersonal interaction or personal meeting if you have any questions. Thank you all.